Good afternoon and welcome to today's CME activity. There is no commercial support. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity. If you're viewing online, we'll list that link in the chat section of the Zoom. And if you're viewing after the fact, you will find the link in the description section of the video. It is my pleasure to introduce Dr. Tanya Aggarwal. She is a third-year internal medicine resident here at Northeast Georgia Health System, and she has accepted a fellowship position in endocrinology at the University of Nebraska. Join me in welcoming Dr. Aggarwal.
All right, good afternoon, everyone. So as Jennifer already introduced, I am Tanya, one of the PGY3s here in internal medicine. Today, I'm going to talk about diabetes 2023 year in review, where we'll talk about some updates in management of diabetes and future directions. Disclosures, I do not have any financial interest or arrangements with any of the corporations providing financial support or with any corporation whose products are featured in this continuing medical education activity. So objectives of today's presentations are going to be to improve treatment strategies for type 2 diabetes by implementing new insulin and non-insulin therapies, improve outcomes for patients with or at high risk of type 1 diabetes by implementing preventive and disease-modifying therapies, improve patient monitoring and clinical outcomes with the use of new diabetes technology. So, outline for today's presentation is going to be background. We'll review foundations of diabetes management, some recently approved and emerging therapies. I'll talk a little bit about diabetes technology and then touch a little bit on updates in type 1 diabetes. So let's start with talking about the scope of diabetes in United States. So here you can see the graph of incidence of diabetes. And as you can see, that there is like an initial rise in the incidence of diabetes from 2000 to 2010. And then we notice this interesting decline. But there were studies which showed that this decline in new diagnosis of diabetes was just in population who identified themselves as white, but the other racial groups, they continue to have increased incidence. But overall, if we see the incidence of like new diagnosis of diabetes, that's been on a downtrend. And on the other hand, there is a prevalence graph which shows the prevalence of diabetes, and it is rising up, which means that the people with diabetes are living longer and longer. So in 2000, it was 1 in 8 people who had diabetes, and now it's like 1 in 10 people in 2000, and now 1 in 8 people. This is just the prevalence of diabetes according to the age groups. So most of the people have diabetes in the age group of 18 to 44, and the prevalence being 1 in 20 people. And then 45 to 64, 1 in 5 people have diabetes, and 65 plus have 1 in 3 people have diabetes. Let's just talk about the cost of diabetes. So total cost of diabetes has actually risen to $327 billion from $245 billion in 2012. There are right now 34 million people who have diabetes in America, and 88 million people have pre-diabetes, and 1 in 7 healthcare dollars are being spent in treating diabetes and its complications. So largest components of medical expenditures are hospital inpatient care. 30% of it goes to that. 30% goes to the treatment of complication of diabetes. 15% for anti-diabetic agents and diabetic supplies, and 13% for physician office visits. So we are spending so much on diabetes. How are we doing? So despite spending so much, only 2/3 of people meet A1C goal. Around 40% diabetics have some form of CKD. 12% have severe vision impairment or loss, and it remains number 7 cause of death in United States. So I just want to remind you all that type 2 diabetes is preventable. 1 in 3 US adults have pre-diabetes, and most of them are young. They are less than 45 years of age. So there was a diabetes prevention program. It was a trial that was done in around 2000, which had 3 arms: placebo arm, metformin arm, and intensive lifestyle arm. So in intensive lifestyle arm, they actually did 1 year of intensive health coaching. Participants were able to lose 7% of their weight with low-fat, calorie-restricted diet. They were made to participate in moderately strenuous exercise for 150 minutes per week. And the results from that were the lifestyle arm was at the top in preventing diabetes, followed by metformin. So in lifestyle arm, almost like 60% of the people we were able to prevent diabetes in. So this was all about the prevention, where we know when the patient develops diabetes, we do have to start them on some medication. So let's just talk about some medications. So back in 2009, it was just a very simple algorithm, 3-box algorithm for diabetes. But it was based on evidence. It was validated by a trial called UKPDS, UK Prospective Diabetes Study. It was a multi-centered randomized trial in which they took 5,000 newly diagnosed type 2 patients, and they were randomized to either A1C of 7% versus 7.9%. And 10-year follow-up on this study was done. So it showed lowered microvascular events by 25%, which was significant. It trended towards lowering macrovascular events by 16%, but at the time of the study, it was not statistically significant. But when they did a 10-year follow-up, it showed 15 to 25% reduction in MI and 13 to 27% reduction in all-cause mortality. And superior outcomes were seen with metformin versus the other hypoglycemic agents. So this was just like a 3-box algorithm at that time, that at diagnosis, you do lifestyle changes, add metformin, and the goal was for the A1C of less than 7%. And if you're not able to achieve that goal, the next step was to add sulfonylurea. And if still you're not able to achieve that goal, the next step is to add basal insulin. So with this, like, I'll just talk about why A1C of like 7%, like why we settled there. So numerous trials in the past have demonstrated that lower the A1C, the better the microvascular complications. This is actually from the DCCT trial, which was a trial for actually type 1 diabetes. So if you see, as we come down on the A1C, the risk of the microvascular complications keep coming down. But with the lower A1C, we have to trade off with the higher hypoglycemic events. So on the other side, if we see, the lower the A1C, the higher the hypoglycemic events. So that was the reason that we had to settle on A1C of like 7%, at which we were able to decrease the microvascular complications and prevent hypoglycemia as well. But if we are able to eliminate that hypoglycemia, then we should always aim for lower A1C, because better the A1C, lesser are the complications. And that was the reason that so many new drugs came in. So this is the new algorithm. This is from the ADA 2023. It looks very complicated, but what it is saying is, first step is the healthy lifestyle changes. That is the most important thing in diabetes management, because there are certain diets that you cannot medicate. No matter how many medications you are giving the patient, if they're not eating well, it's very difficult to control diabetes. So, and then after those healthy lifestyle behaviors, then basically they divided based on what is your another goal with diabetes. Is it, if patient has high ASCVD, then you can add either a GLP-1 receptor agonist with proven CVD benefit, or SGLT2. If patient has heart failure, then you can add SGLT2. If patient has CKD, then again SGLT2 inhibitor. If the goal is mainly the weight management, then the GLP-1 receptor agonist. And even in that, efficacy-wise, semaglutide and tirzepatide are very highly efficacious. Then dulaglutide, liraglutide, and then the other ones. And the metformin and DPP-4 are the weight neutral. And if there is nothing, patient does not have any other risk factor and you just have to control diabetes, then you can choose like metformin or other therapies based on cost, patient preference. So the change that this ADA made in 2023 was earlier metformin used to be up here with the healthy lifestyle, but then they removed it and put it just like here. So this is the simplified version. I still kept metformin on the top because I still believe that metformin is a wonderful drug. It is 200 plus years old drug, but still we do not know many good things about metformin and studies are still going on. So I think when the patient first gets diagnosed with diabetes, like it's not wrong to start them on metformin. And then based on what other risk factors they have, we can keep adding, like for heart failure, SGLT2, CKD, SGLT2, weight loss, GLP-1. But lifestyle changes, they remain stable throughout. All right, so we'll now talk about separately about the different therapies. So first I'll talk about the GLP-1 receptor agonists or incretin analogs. So this is how GLP-1 receptor agonists work. So when we eat carbohydrates, it gets broken down to glucose. In our small intestine, we have SGLT1 receptors, which helps in absorption of glucose. Then there are enteroendocrine cells present in our intestine, which releases incretin hormones, GIP and the GLP-1. These hormones, then they go to their receptors, and the main ones are in the beta cells of the pancreas. So they get attached, and there is increase in the cyclical AMP activity, which leads to increased insulin secretion, and that's how they help with diabetes. So these are some of the places where the GLP-1 receptors present. So first and foremost, the most important one are the pancreatic beta cells, which helps in insulin secretion, glucagon suppression, and that's how they help with diabetes. Then GLP-1 receptors are also present in hypothalamus, brainstem, and that helps with satiety, and that's how these drugs help with obesity. Then vagal neurons, that's how they slow the gastric motility, and this is responsible for the side effects of nausea, vomiting. But this effect is achieves tachyphylaxis in about like 6 to 8 weeks. So we can counsel the patients if they're complaining of nausea and vomiting that these effects usually go away in 6 to 8 weeks. Then GLP-1 receptors are also present in pancreatic acinar cells, and that's thought to be the possible cause of how GLP-1 causes pancreatitis. But still, how actually it causes pancreatitis is still not known, and studies are going on. And then GLP-1 is also present on, receptors are also present on SA node, and that's how it causes tachycardia. So these are some of the GLP-1 receptor agonists that are currently available in the market. So we have liraglutide or Victoza, then we have exenatide, we have Trulicity or dulaglutide, we have semaglutide, Ozempic, it's either Ozempic, Wegovy, and then Mounjaro. So these are the ones that are currently present in the market. And right now, the only formulation that's available in the market, the oral formulation is Rybelsus or oral semaglutide, and we'll talk more about it later. So now I want to talk about like some of the GLP-1 receptor agonists which are under trials and which will soon be coming out. So one of them is this retatrutide. It's a fatty acid acylated single peptide that is engineered from a GIP backbone. It is dosed weekly, And how it works is it activates the GLP-1, GIP, and glucagon receptors. The question I had when I saw this, that how a glucagon receptor activator can help with diabetes. And that was interesting when I read, because glucagon does the opposite of what insulin does. So what they are seeing is like retatrutide, it has like a preferential stimulation of receptors. So it stimulates mostly the GIP, then GLP-1, and then the glucagon. And they have seen that the glucagon helps with satiety. So it increases your satiety, and it also increases your energy expenditure. So that might be the possible causes that how retatrutide can actually help with diabetes and weight loss. So there was a phase 2 trial of retatrutide in which they compared this drug with dulaglutide, and they saw that there was 2% decrease in A1C with retatrutide as compared to 1.4 with dulaglutide. And in terms of weight loss, there was 17 kilos weight loss with retatrutide as compared to 2 kilos with dulaglutide. And 40% achieve more than 20% weight loss on this medication. And since it activates GIP, it causes very little nausea. And phase 3 trials are just beginning for this medication. Another one is orforglipron. This is interesting. In the slide that I showed you earlier, I showed you that there is only one oral formulation that's currently available in the market, and that's of semaglutide. But that's a peptide GLP-1 receptor agonist. So what happens is when we eat a peptide, when we take a peptide GLP-1 receptor agonist, it has a poor bioavailability because it causes hydrolysis by digestive enzymes in the GI tract, and it also has a low permeability. So the data shows that the oral semaglutide has bioavailability of only 0.4 to 1% as compared to its injection form, which has 89% bioavailability. So these new drugs that are coming out, these are non-peptide GLP-1 receptor agonists. So they have better bioavailability and almost comparable to some of the other injectable forms of the GLP-1 receptor agonist. And there is like no food interaction, so you don't need to fast before or after administration. Whereas with the oral formulation of semaglutide, it requires fasting at least for 30 minutes before and 30 minutes after administration. So there was a efficacy and safety trial on this orforglipron in which they actually compared dulaglutide with placebo and orforglipron. So this is already in the market, dulaglutide. They took 383 patients, divided into 3 groups, and the outcome was change in HbA1c compared to baseline at week 26. So what they saw was there was decrease in A1c of 2% with the maximum dose of orforglipron, whereas 0.4% with placebo and 1.1% with dulaglutide. So actually, orforglipron had a better efficacy in terms of reducing A1C than dulaglutide. And in terms of weight loss, there was 10 kilos weight loss with orforglipron as compared to 2.2 with placebo and 3.9 kgs with dulaglutide. So again, in weight loss, this oral medication has better outcomes than the already existing injectable form. The limitation of this study was it was a small sample size and short study interval. This is just the graphical representation of what I just talked. So here you can see the placebo just changed it by 0.4%, the A1C, dulaglutide was 1.1% and 2.1% with 45 milligram dose of orforglipron. In terms of weight, again, 3.9 kilos with dulaglutide and 10.1 kilos with 45 milligram dose of orforglipron. Another one in the similar class is danuglipron. It is also an oral small molecule non-peptide GLP-1 receptor agonist. It's a phase 2 randomized control trial. They took 400 participants and compared danuglipron with placebo. They escalated doses every week till the patient reaches 40 milligram or more twice daily. And the outcome was the danuglipron administration reduced the A1C at all the doses, whereas for weight loss, it achieved that effect at the dose of 80 milligram or more twice daily. Again, limitations were short duration of study. They just studied for 16 weeks, and then they rapidly escalated the doses every week. So this was the data from the study, that here you can see the danuglipron at all the doses was able to reduce the A1C, whereas in terms of weight loss, only 80 and 120 milligram was able to achieve like good effect. So good things with this oral GLP-1 receptor agonists is, I think, that some of the patients, they have fear of needles, they don't want to inject themselves. So this once these come out, I think they will be a game changer, because they have shown great efficacy in terms of safety. They are almost similar to the ones that are currently available. So it would be very easier for the patients to like take these medications. Next, we'll talk about the SGLT inhibitors, or sodium glucose cotransporter inhibitors. So how do these medications work? So there are SGLT2 channels in our proximal convoluted tubules in the kidneys, which is responsible for 90% of glucose reabsorption. So when we block these channels with SGLT2 inhibitors, we excrete all the glucose in the urine, causing glucoseuria, and that's how they help with the blood glucose. So these are the SGLT2 inhibitors which are currently available in the market. So dapagliflozin or Farxiga, empagliflozin or Jardiance, these are basically approved for glycemic control in diabetes. It has cardiovascular indications both in diabetics and the non-diabetic people. And they have kidney indications, like people who have CKD, both in diabetics and non-diabetics. So it's actually FDA approved for all of this. Same with Jardiance, it has been FDA approved for all the indications. And there have been trials like DAPA-CHF, DAPA-CKD, and for this, there was an EMPA kidney trial which showed benefits in CKD patients. And this actually got approved for CKD just recently in September 2023. Then canagliflozin for glycemic control and for cardiovascular and kidney indications only in diabetic patients. Then sotagliflozin is interesting. It has not yet been approved for glycemic control in diabetes, but recently there was a cardiovascular outcome trial after which it got approved for cardiovascular indication in diabetics and non-diabetics. And then these are the other ones, ertigliflozin and bexigliflozin. So talking a little bit about the new ones. So bexigliflozin, this got approved for diabetes in 2023, January. It's a single dose. You have to give 20 milligram daily. Good thing about this medication is that its cost. It only costs $50 for 1 month supply as compared to other SGLT2 inhibitors which are currently available in the market, which cost around $400 to $500 for 1 month. So this is something would be very good for the patients who cannot afford the high cost of SGLT2 inhibitors. And there have actually been multiple studies done on this, which has showed similar efficacy and safety profile as compared to other SGLT2 inhibitors which are available in the market. Currently, it is only approved for type 2 diabetes, like glycemic control, but there is already a data showing benefits in like for CHF patients, for CKD patients. So I'm hoping like in the near future, it will get approved for those things as well. This is the one, they studied bexigliflozin in stage 3A and stage 3B CKD patients. So you can see decreased A1C, decreased body weight. And interestingly, this drug also decreased their SBP by 3.8 millimeters of mercury. And actually, they are studying now this drug as a medication for hypertension. and it had like similar safety profile. Another one I want to talk about is sotagliflozin. What is special about this medication is that it's a combined SGLT2 and 1 inhibitor. So SGLT2 inhibitor, we already talked about how it works in our kidneys. The SGLT1 receptors are actually present in our small intestine. So it blocks those receptors and you start excreting glucose in your stools as well. So it has a double benefit. It is interestingly, this drug has been approved in Europe for the treatment of type 1 diabetics. It lowers the studies that they did in Europe that showed that it lowers A1C by 0.5% more than placebo, improves weight and blood pressure. DKA definitely occurred in 3% versus 0.6% in placebo, but it is not yet approved in United States for type 1 diabetics. In fact, none of the SGLT2 inhibitors are right now indicated in type 1 diabetics. So this was the sotagliflozin cardiovascular outcome trial, after which it got approved for in May 2023 for cardiovascular indications with or without diabetes. So it was a multi-center double-blinded trial. They took 10,000 participants with type 2 diabetes who had CKD and who had a cardiovascular risk. They compared this with placebo, and what it showed was with sotagliflozin, only 400 events of these outcomes occurred, whereas 513 placebo group. And the adverse events that this saw was diarrhea, which is understandable since it blocks the SGLT1 receptor in our intestine. Then it causes DKA, genitourinary infections, and volume depletion. This study only included patients who were diabetic, but after this trial, the effects were so significant that they approved both for diabetics and non-diabetics who have cardiovascular indications. So that was about the SGLT2 inhibitors and the GLP-1 receptor agonists. Next, I want to talk about the new insulin that's coming in the market, and that's insulin icodec. So there was this trial. It has already completed its phase 3 clinical trial. So it is actually a once weekly basal insulin. So you have to inject yourself only once a week. In this trial, they compared glargine 10 units daily with icodec 70 units weekly. So the dose was the same, like weekly dose, but this is weekly and this is daily. And what they saw was that it has a slightly better glucose lowering effect than glargine without additional hypoglycemia and similar total daily dose and similar weight gain. And it is expected to be FDA approved this year in April. So if you look at the graph, the A1C with icodec, it's little low as compared to glargine. If we look at the CGM readings with icodec, you see the people are more in the green range as compared to glargine. This is just a pictorial representation of what I just talked. So this was a trial that around 490 patients, they gave icodec, and the other rest of them, they gave glargine U100. Again, there was more decrease in A1C. The percentage of time that the patient spent in the desirable glycemic range was more with icodec as compared to glargine. So it did show a little bit of more hypoglycemic events, but it was not statistically significant. So overall, it was more efficacious in controlling blood glucose as compared to daily glargine. So that was about the therapies, and now I'll talk about diabetes technology, in which I'll talk about like CGMs and the insulin pumps. So CGMs, there are two available in the market, Libre 3 and Dexcom. So the new one that came out was Libre 3 and Libre 2 was the old one. So the main difference is in Libre 2, the sensor size was big and it was thick. The sensor with Libre 3 is smaller and it is thin. So it's almost half the thickness of the Libre 2 sensor. And then Libre 2 came with a two-piece applicator. So one had like a sensor and you have to load that and then put it on your arm. But this is a one-piece applicator, so it comes preloaded, so it's easier for patients. And then in Libre 3, you don't have to scan, so it keeps sending the readings to your smartphone every minute. Whereas in Libre 2, it used to come with a reader, so either you can use a reader or your smartphone app to actually scan, and then it gives the reading. So there are some benefits on that, but none of these are still they're not integrated with insulin pumps yet. Then Dexcom G6 and G7. So G6 is the older one, G7 is the new one that's coming, that just came. It got approved in December 2022. Again, with G6, the sensor is larger and bulkier, whereas with this, it's very small. And what benefit does it give is that being a small sensor, you can even put it on the back of the arm, whereas with this, it always had to go on your abdomen. So people who used to inject insulin, they get more space for injecting themselves with this one. Again, it is all in one sensor and transmitter, so it's just one piece, whereas with G6, it used to be two piece. So this white thing was a sensor, and then the purple thing was like a transmitter. And then, so this G6 is integrated with all the insulin pumps which are currently available in the market. But with G7, they have not yet integrated this with the pumps, but it should be happening soon. And I want to talk about the Medicare coverage for these CGMs. They expanded their coverage for CGMs in April of 2023. So earlier, they required the patients to be on multiple doses of insulin, that is 3 or more daily administrations of insulin, or patient should be on a continuous insulin infusion pump. But now they have changed that to the patients who are taking insulin, irrespective of how many doses of insulin they are on. So even if they are on once daily insulin, so they will qualify for CGM. Or if you can report, if the patient can report severe hypoglycemia or recurrent non-severe hypoglycemia despite attempts to modify the treatment plan. So even if patient is not on insulin, and it requires every 6-month visits to document adherence. So next are the insulin pumps. So these two ones are Omnipod and Tandem. These were the old ones. This is the new one that's come in, and this is something amazing that has come out, the bionic pancreas. Why it is interesting is that, so in all of these pumps, like 780G, Tandem, Omnipod, endocrinologists had to make like a lot of settings before the patient actually starts using them. Like you have to set the carb ratio, correction factor, the basal doses, like the basal rate that you have to set. And even when patient was using, they have to put like total grams of carbs in their meal. So they have to enter those, and then the pump delivers the insulin. Whereas with bionic pancreas, the only thing that you have to put in is the weight of the patient. So it is very easier for the physicians. So even the primary care physicians can start these pumps. And also it gets easier for the patients because they don't have to enter the grams. So they just have to enter whether the meal was usual for them, less than usual, or more than usual. And the pump will calculate the doses by itself and deliver. And it just got approved by FDA. So you can see, so there has been a data. This blue one is the bionic pancreas, and the red one is the conventional insulin. So the percentage time spent in desirable glycemic range, it is much better with the bionic pancreas, and the mean glucose levels is lower than the traditional forms. And then especially it has benefited those patients who have higher A1C to begin with. The A1Cs have significantly improved. And even if we look at the hour-to-hour data, so this blue thing is the bionic pancreas, and the red one is the traditional form. So you see the mean glucose levels are much better controlled as compared to the red ones. So that was all about the diabetes technology. Now some updates in type 1 diabetes. So teplizumab is the one that got approved last year. So what is teplizumab? It's like a preventative therapy for type 1 diabetes. It's a monoclonal anti-CD3 antibody. So it gets attached to the CD3 receptors on the effector T cells, preventing them from attacking the beta cells. So that's how they work, but you have to screen the patients and pick them up in stage 2 of pre-diabetes. So there are different stages. So stage 2 is when they have these antibodies present, like GAD, IA2, zinc transporter antibodies, and their glucose level is not in the range of symptomatic hypoglycemia, but there is a impaired glucose tolerance test. So if patient is in this category, you give teplizumab, and it will bind to your CD3 receptors on the T cells and delays the onset of stage 3 or a full-blown type 1 diabetes. But these are 30-minute infusions. You have to give over 14 days, and it costs, so one vial costs around $13,000, and 14-day course will cost about $200,000. So this was the data that was published in NEJM. They looked at the teplizumab versus placebo. So proportion free of type 1 diabetes was higher with teplizumab than with placebo. So if you look at the numbers, so 19 of the 44 participants who received teplizumab and 23 of 32 who received placebo had type 1. So less number of people in teplizumab had type 1 diabetes. The annual rate of diagnosis was around 15% in teplizumab group and 36% in placebo group. Median time to diagnosis was 48 months in the teplizumab group and 24 months in the placebo group. So the data was quite impressive. And this is something that just got approved, donislicel. What it is, it's the first allogeneic pancreatic cell transplant for the treatment of type 1 diabetes who have unsuccessful control of their A1C despite intensive diabetes management. It got approved in June 2023, and this was based on 2 non-randomized single-arm studies in which total of 30 participants with type 1 diabetes and hypoglycemic unawareness received at least 1 infusion or a maximum of 3 infusions. And what did they see? That 21 participants did not need to take the insulin for a year or more, and 5 participants did not achieve any days of insulin independence. And out of 21 participants who did not need to take insulin for a year or more, 11 participants did not need for 1 to 5 years, and 10 participants did not need for more than 5 years. But honestly, if you ask my opinion, is this practical? I would say no, just because you have to rely on a donor, and type 1 diabetics, they are usually young, and it requires lifelong immunosuppression, and you are putting them at risk of so many infections and a lot of things. And it costs around $300,000. So it's not really very practical. So they're also studying Vortex 264. This is also an islet cell therapy, but what they are doing is they are encapsulating those stem cells with the hope that this could eliminate that lifelong need for immunosuppressive medication. But this is still under phase 1 and phase 2 study. So that was all for my presentation. I have 2 questions, and then I'll open the floor for you guys to ask questions if you have any. So which SGLT inhibitor has been approved only for cardiovascular indication with or without diabetes? And the options are empagliflozin, sotagliflozin, dapagliflozin, or canagliflozin.
And would you like someone to answer?
Sure.
Okay. Oh, here we go.
Sotagliflozin.
Correct. All right. Next question is, which is the non-peptide GLP-1 agonist under trial for management of diabetes and weight loss? Danuglipron, retatrutide, semaglutide, or liraglutide?
Is it 2?
No. So non-peptide, you remember I talked about like the oral formulations, the non-peptide ones, which are coming.
3.
Hmm?
I'm not sure.
We need to phone a friend.
I wasn't here for the first half.
We need to phone a friend.
Was it 3?
So so 3 is the peptide GLP-1, which is currently available.
Hold on, we're going to phone a friend.
Okay.
Is it 1?
Yes. So danuglipron or orforglipron, these were the 2 non-peptide oral formulations which are currently under trial, like for oral GLP-1 receptor agonists. These are my references.
She's a student.
I want to thank you all for coming and listening to my presentation, and I want to thank Dr. Fung, who actually helped me in putting all this together. All right, what questions you have?
Yes, and if you're viewing online, please enter your question into the chat and we'll ask Dr. Aggarwal. So in the room, any questions or comments?
One of the things that wasn't overwhelmingly touched that I like, in medicine, I agree with you, glucophage is the greatest thing invented for type 2. But my patients, when I was practicing, I retired 50 years ago, happens to be that I not only treated the diabetes, I treated them with the diet, the appropriate diet that they should have. The degree of fasting, anywhere from 18 to 20-hour fasting that the body should have to recover. Sleep studies also, because the majority of these people suffer from severe sleep apnea. So they wake up and what do they want to do? They want to go to Dunkin' Donuts and buy sugary, nice donuts. And I don't blame them. It's the body being sick. The other thing that I treat, and I treat it because once the beginning is the liver gets fatty, okay? So you got a steatotic liver. So essentially the liver is not functioning, period.
Mm-hmm.
And the second thing that it invades is the pancreas. And then after that, the intestine and the whole thing, so the fat begins to form more and more in these patients. And what I treated them was, it's been well known, even during the Roman Empire, they had it as milk thistle, along with choline, and even a little thing called tudka, Tuda, tudka, sorry, Ca. That helps cleanse and clean and regenerate the liver, because the liver does and can regenerate, but you got to help it. And among all these things, I try to tell them to go either swimming or weightlifting, do some kind of exercises to begin walking, more slow walking, because think of yourself in a treadmill, 300 pounds running in a treadmill. Those knees, the ankle, the hips, the back is going to fracture. It ain't going to work out. So simple as that.
Mm-hmm. Yeah, I agree 100%. Like diet and lifestyle is something which would remain like constant for diabetes management. Like that, as I said, you cannot medicate certain kind of diet, or like if your lifestyle is not good, you cannot medicate them.
Oh, one more.
And you know what? I'm going to be honest with you. I don't know. It to be one of these people who think, that everybody's kind of, doing things to promote unhealthy people in the United States. Because now everywhere you go is supersize, number one. Everything is sugar. Everything also happens to be, even in schools, they put Coca-Cola machines. The worst thing you can drink, one of the worst things you can is sugar. And the worst kind of sugar is corn syrup, which has a lot of the worst sugar. You got glucose and fructose. Fructose is the worst. Well, they're all bad, but fructose is the worst. By the way, milk also.
Yeah, I agree.
The monoclonal antibody, do you know in the trial, did they test to see if there was slower progression in stage 1, or how did they decide on initiating in stage 2 specifically?
So they only studied in stage 2 because I guess in stage 1, it's very difficult to diagnose them. Because I know you can like test for the antibodies in stage pre or the stage 1, but their glucose tolerance test is normal. So I guess it's very hard to like diagnose people in that stage because if somebody has impaired glucose tolerance or like and then has those antibodies, that's when they're studied, but there are no studies for like stage 1 or pre-diabetes yet.
Thank you, Dr. Aggarwal.